So welcome to the Nutrition Science and Practice Conference, the annual conference of the American Society for Parenteral and Enteral Nutrition. I am Pat Becker, the session moderator, and this session is T23, Identifying Malnutrition in the Preterm and Neonatal Population Recommended Indicators. Please take your seat. And I'm not going to ask you to move to the center. You're all just fine where you are. So don't even worry about it. But do please silence your cell phones or other electronic devices. We do recommend that you not take photographs. All of our presentations are on the e-learning center, and you can access them. Conference evaluations and claiming of CE credits are done online, so please refer to the on-site program book for details. We're going to hold all questions for the end of the sessions, and there will be microphones in the aisles for that purpose. So I will introduce myself first. I am Patricia Becker. I am a board-certified nutrition support clinician and certified in pediatric specialty. I am the corresponding author on the consensus statement for pediatric malnutrition, and I currently work at Dayton Children's Hospital in Dayton, Ohio. Our second speaker is Dina Goldberg, and she is a PhD. She works at Caroline Children's Clinic in Roanoke, Virginia, and she is the corresponding author on Identifying Malnutrition in the Preterm and Neonatal Population Recommended Indicators, which is an article in press and hopefully will be published in the Journal for the Academy of Nutrition and Dietetics in the spring of this year. Our third speaker this afternoon is Susan Carlson, MSSC, RDN, CSP. She's board certified specialist in pediatric nutrition. She's a neonatal dietitian in the Department of Nutrition at the University of Iowa Stead Family Children's Hospital, the University of Iowa Hospitals and Clinics in Iowa City, Iowa. She will be presenting Putting the Preterm Neonatal Malnutrition Indicators into Practice. Okay. Oops. So sorry about that. All right. Let me get this going here. All right, I have no disclosures. So why do we need a standardized definition? So I don't know if you're aware, there's a consensus statement for the adults, and this all happened back in 2010. The Centers for Medicare and Medicaid came to the Academy of Nutrition and Dietetics and Aspen and said, we need a standardized definition of malnutrition. We have people coding for malnutrition, and there is no standard definition. And so why do we need a standard definition? In the paper that came out in 2013 in Nutrition and Clinical Practice, defining pediatric malnutrition, a paradigm shift, the lack of a uniform definition is responsible for the under-recognition of the prevalence of malnutrition and its impact on the outcomes of children. This lack of a uniform definition impacts all populations, adults, children, and our neonatal and preterm populations. Why do we need characteristics to identify malnutrition? The universal use of a single set of diagnostic characteristics will facilitate the identification, documentation, and treatment of malnutrition related to undernutrition. It will further contribute to more valid estimations of prevalence and incidence. It will help guide interventions. It will promote and support monitoring and evaluation and optimize outcomes. Hospitalized patients of all ages, from preterm infants to the elderly, typically suffer from malnutrition related to undernutrition because of reduced intake, often combined with increased need, inflammation, infection, and other catabolic states. In addressing disease-related malnutrition in hospitalized patients, a call for a national goal, recommended actions were that each clinician on the interdisciplinary team should participate in the execution of the nutrition care plan. The healthcare community should develop systems to diagnose malnourished patients using consistent definitions, screening, and assessment tools. There is a wide variation in incidence and prevalence in acute care. There are requests from clinicians for best criteria to diagnose malnutrition. There are multiple ICD-10 codes to diagnose malnutrition. There is limited evidence on which to base these diagnoses. And what is the role of inflammation in response to malnutrition? So what was our purpose? The goal of the Pediatric Nutrition Practice Group, Preterm, and Neonatal Malnutrition Work Group was to review the medical literature, provide a framework for the identification of preterm and neonatal malnutrition, and to define indicators for its identification. Malnutrition in the neonatal and preterm population can have lifelong consequences. As with adults and children, early identification and documentation and treatment of malnutrition is critical to improved outcomes. The attributes of our recommended indicators were that they would be basic parameters, that they would be few in number, they would be easy to obtain, that they would support a diagnosis of undernutrition, that they would characterize severity, that they would reflect change in nutritional status rather than degree of inflammation or disease acuity, that they would be evidence-informed and consensus-derived, and that they would change over time as validity accrued. So the lack of a uniform definition is responsible for the under-recognition of the prevalence of malnutrition and its impact on the outcome in children. So with the adult consensus statement, 2 parameters are required to be present. It just indicated non-severe and severe malnutrition. It indicated illness-related and non-illness-related malnutrition, acute and chronic, indicated loss of muscle mass, loss of fat mass, and fluid accumulation and functional status. In the pediatric consensus statement, we had mild, moderate, and severe malnutrition, acute and chronic. We differentiated illness-related and non-illness-related malnutrition. We had single data point indicators and multiple data point indicators. We based our single data point indicators on Z-scores. And with identifying malnutrition in the preterm and neonatal populations, our recommended indicators included weight, number of days to regain birth weight, weight gain velocity, change in weight for age. We also used Z-scores. We had length indicators with linear growth velocity, change in length for age Z-scores, nutrient intake and consecutive days with suboptimal intake. So identifying malnutrition in the preterm and neonatal populations, recommended indicators. These attributes were selected to meet the following criteria. They were evidence-informed and consensus-driven. They are universally available and easily obtained. They are easily applied in all settings, whether that be the hospital setting, whether that be the outpatient setting after discharge, that they are easily reproducible with little training, and that they would support a diagnosis and characterize severity, that they would reflect change in nutritional status, and that they may and will change over time as evidence of validity accrues. Okay, so we're waiting for a minute while our second presentation gets delivered on a flash drive. Is that correct? Is our guy back? Okay. All right, so there will be a pause. Where did our guy go?
Yeah, I'll have to apologize, but the computer ate my presentation on the flash drive.
Yeah, we had a technical difficulty. We could just do yours. Do them out of order.
That's fine.
Not good.
I don't see why not. I mean, it won't be as obvious, but I think in the.
You think we should do it?
Some more time. Yeah.
We might do these out of order. Go, let's do it. Wait.
Okay.
He's back. Yay!
Oh, you're going to need it.
So you know the old adage, anything that can go wrong will go wrong? Yeah, that's the kind of day I'm having. So thank you for your patience.
I'd like to welcome you all personally, and I appreciate you all coming to hear about the hours and hours of work that my committee and I put into this. I have no commercial relationships to disclose, and the objectives are to describe the process used to develop the criteria for identifying malnutrition in preterm infants, to describe the indicators recommended for use in diagnosing malnutrition in preterm infants and neonates, and discuss areas for future research and work. In terms of how this all started, I find it's kind of hard for me to remember, actually, but I do know that one day our pediatric coders came to me and said, please code for malnutrition in the NICU. And I said, I don't think I can. There are no carefully thought out peer-reviewed criteria for diagnosing malnutrition in preterm infants and neonates. And they said, oh, right. So the next thing I know, I'm chairing a committee that's developing these criteria. And so our committee was sponsored by the Pediatric Practice Group of the Academy of Nutrition and Dietetics. And this was a group of experienced RDs that started their work in the spring of 2016. And this is the list of the committee members. There are names on there I'm sure you'll all recognize. And I also want to acknowledge Susan Carlson for the slides, because she gave us this similar presentation to what I'm doing in Minneapolis at the Neonatal Nutrition Conference, and gladly shared her slides. So a lot of this work is on the slides is Susan's. So the first thing that we did was review the literature that was available on premature infants and measurements of nutritional adequacy. We looked at weight, length, head circumference, mid-upper arm circumference, nutrient intake, and then we decided which of those would be applicable, met the criteria that Pat described for indicators of malnutrition. And we really used this process was guided by the pediatric consensus statement, and you'll see the way that we formed the indicators are based on the pediatric consensus statement. So we did develop a draft manuscript with draft indicators and asked healthcare professionals interested in neonatal nutrition and growth assessment to review and give us their feedback. And our paper is in press in the Academy of Nutrition Dietetics, and I expect it to be out within the next couple of months. So let's get our definition straight so we'll know exactly who we're talking about. Neonates are infants born at term, that's 37 weeks or greater, and less than 28 days. Preterm infants are all infants born at less than 37 weeks. So one of the first things that we did was we had to define what is malnutrition in preterm infants. You can't diagnose it if you don't know what it is. So we were unable to find any papers that used the term malnutrition or gave a concrete definition of the term for preterm infants. There's a plethora of literature on extrauterine growth retardation, postnatal growth failure, and the impact of a variety of nutrition practices on improving growth and or medical and neurodevelopmental outcomes. So, the basic assumptions that we went on is that malnutrition is due to inadequate or imbalanced intake of nutrients or their impaired assimilation or utilization. Infants with malnutrition will demonstrate impaired growth. Therefore, evaluation of growth parameters and growth changes over time is an appropriate tool to screen for malnutrition. So growth assessment at birth is an important benchmark for evaluating changes in nutritional status and goals for discharge. However, comparison of birth weight to a standard is complicated by several factors: maternal characteristics, the uterine environment, gestational age are all going to influence size at birth. In addition, determining an accurate gestational age may not be easy to do, especially if you do not have from early prenatal care, early pregnancy dating, or ultrasound. And I have a classic example right now of that in my NICU. We have an infant born at 28 weeks that was like 1,800 grams, and that's what got in the medical record that this was 28 weeks, although when you talk to the neonatologist, this infant was probably older. So antenatal malnutrition occurs when the fetus is unable to meet his or her fetal growth potential due to maternal malnutrition or maternal medical conditions that impair nutrient flow from the mother to the placenta or placental insufficiency. So we're going to talk about small foot gestational age and intrauterine growth retardation and differentiate between the two. Small foot gestational age if that's symmetric, would be infants born with weight, length, and head circumference with a z-score of less than 1.28 or the 10th percentile. So all of those growth parameters are below average. That better? Thank you. Asymmetric would be just having the weight z-score less than the 10th percentile. So these infants may be malnourished or they may be well-nourished because by definition, 10% of infants are going to be below the 10th percentile. With infants demonstrating fetal growth rate below full genetic potential are intrauterine growth restricted. And this can be difficult to identify if you don't have an OB history or early Doppler studies of infant growth. So if you don't have the history to date or the Doppler studies for growth, again, we have the issues with determining exact gestational age. Intrauterine growth-restricted infants are more likely to have experienced antenatal nutrition than a small for gestational age infant. And these would be diagnosed by growth failure, but normal head circumference, but, or abnormal Doppler volumetry. Common conditions associated with intrauterine growth retardation would be multiples, preeclampsia, eclampsia, maternal diabetes with vascular complications, absence or reverse end diastolic flow, indicating placental insufficiency, or twin-to-twin transfusion syndrome. Postnatal malnutrition risk factors for infants born small for gestational age or intrauterine growth retardation. So these infants may or may not be malnourished at birth. And if they're not malnourished at birth, then reduced nutrient stores put them at risk for developing malnutrition during their stay in the NICU, particularly when nutrient intakes are insufficient. So these, we looked at the components we were using for our malnutrition screen, our weight, length, nutrient intake, so I'll be going over those. And then I'll talk about other components such as head circumference and mid-upper arm circumference that we looked at and decided at this point we were not ready to recommend them for use to diagnose malnutrition. So these are the weight indicators. And we have days to regain birth weight, decline in weight for age Z-scores, and a weight gain velocity. And so days to regain birth weight, as I've highlighted here on the slide, does require a second positive indicator to determine malnutrition. Because we know that infants lose 7 to 20% of their weight during postnatal diuresis. And that is why we would not recommend changes in weight Z-score or weight velocity for use to indicate malnutrition during the first 2 or 3 weeks of life. So most infants will regain birth weight by day of life 14, not necessarily all of them. And since the weight, optimal fluid balance and optimal nutrition can mitigate the duration of postnatal diuresis and poor growth, adequate nutrition would be a component of this, because adequate nutrition would contribute to a shorter duration of weight loss and poor growth. So, so we are saying that this would logically be used. This indicator would logically be used with nutrient intake, and we'll discuss nutrient intake later. So, one of the weight indicators was the decline in weight for age Z-score. And you can see we've made cutoffs for mild, moderate, and severe malnutrition. These cutoffs are more different from the pediatric consensus statement. They're more stringent. And that's simply because with this population, we felt this was more appropriate. We do know in a paper by Dr. Eckhart Ziegler and Sue Carlson that they state that decline in Z-score of 0.6 or 10 percentile points during postnatal diuresis would be unphysiological. And work by Rocho and his colleagues indicated that what infants tend to do is to transition to a trajectory that's about 0.8 standard deviations away from their birth Z-score. So that's how we came up with those cutoffs. And again, this again would not be appropriate for use in the first couple weeks of life. So the tools that we would use to determine weight for age Z-score and growth velocity indicators would be our preterm growth charts. In our paper, we do summarize a discussion of growth charts that have been developed and are, many years ago and even more recently, and summarize their strength, what we consider some of their strengths and weaknesses, and really, at this point, feel for the purposes of diagnosing malnutrition, the Fenton or Olson growth charts are the most appropriate. And it really doesn't matter which one you use as long as you're consistent. So this is, I think this is, we recommend that you use PD tools. If you're not familiar with it, you may want to go to the website that's listed here and check it out. But this is the information that you would gather from PD tools. In this example, you've got a 27 and 2-day-old male weighing 930 grams, and if you put this information into PD tool, you'll find he's at the 39th percentile with a Z-score of minus 0.28 and an expected weekly gain of 121 grams to maintain that Z-score. And here, when he's day of life 32, he's now 31 and 6 days, and you can see this baby now weighs 1320 grams, and he's now at the 20th percentile with a Z-score of minus 0.69, and expected weekly weight gain of 188 grams. And so you can easily calculate the change in Z-score, which in this case is minus 0.1 from birth. And so the last weight gain indicator would be weight gain velocity. And so you see the cutoffs here for mild, moderate, and severe malnutrition. And again, this is not appropriate for use during the first 2 weeks of life. So severe malnutrition is gaining less than 25% of expected growth, moderate 50%, and mild 75% of expected growth. And again, as you can see how you can get that information from PD tools. We do recommend that you use grams per day instead of grams per kilogram per day to do your growth assessment and set your growth goals. The reason behind that being is that 20 to 30 grams per day has been shown to mitigate extrauterine growth retardation and improve neurodevelopmental outcomes. And also that weight gain goals vary with gender, age, and size. So if you have a 32-week-old female weighing 1,400 grams, her Z-score is minus 0.776. And so, and if at 33, and she needs to gain 22 grams per kilo per day to maintain that Z-score. And if you look at her a week later, she's 1,600 grams, and her Z-score is at minus 0.76 still. She needs to gain 18 grams per kilo per day to continue on that growth trajectory. So the other issue with grams per kilo per day is that the method of calculating this influences the result. And in the paper, we do give you references for looking more into that. But it really makes a difference what weight you use for the denominator. Do you use birth weight? Do you use the average of your weight from your 2 points? And that will and that does influence the results. And it's Dr. Fenton who wrote a very nice paper describing that. And the other thing is that weight gains, as I've already shown you, of 15 to 16 grams per kilo per day, or the 25 to 35 grams per day when they hit 2 kilos, may actually estimate gain needed to maintain their Z-score. So the other thing to take in consideration is fluid balance, and because shifts in fluid may cause non-nutritional changes in weight. So you have fluid changes with surgery. I mean, I had a little tiny one gain 500 grams after she had surgery, and then lost that. And so when she diureses, you don't think of her as being malnourished because you're expecting her to get rid of some of this weight. And so you need to look at renal issues, any medications that may influence urine output. So with small for gestational age, these infants may require some special consideration. And one of the things you need to think about is what is their genetic potential. And as I've already referred to, an SGA infant may be appropriate. That just may be where she or he is meant to be. Large for gestational age, that again may be where genetically they're supposed to be, or particularly with infants of diabetic mothers, you're going to expect to see a regression towards the mean. So you can use the WHO Growth Standards website to get weekly weight gain goals for the 5th, 10th, and 50th percentile for the first month of life for infants 2 kilos to 4 kilos plus. And one thing you want to take in consideration is, though the median can be used as a goal, really only 6% of infants are going to grow at the 50th percentile when you remember the shape of the bell curve. So you want to determine growth goals individually. And we are not actually get into prescribing catch-up growth because that best rate of catch-up growth is unknown, because you are balancing optimal brain and neuro development along with risks for cardiac and metabolic syndrome later on in life. Okay, so length, we have similar criteria for length, linear growth velocity and the decline in length for age Z-scores. And you can calculate this information. It will be exactly the same with PD tools. It will give you the same information that I showed on length. We did decide that length requires a second positive indicator because we know that there is a strong link between length, brain development, and neurocognitive development, and that accretion of fat-free mass, linear growth requires accretion of fat-free mass and adequate protein and other calories and other nutrients. So we did set that a second indicator along with this would reinforce that this length is a nutrition problem. So length indicators are appropriate for use only when accurate length measurements are available. And that's something I personally am working on in my unit. We've got length boards, and I have found that getting a policy in place about how to correctly use length boards and asking that length boards be used, that we've increased the percent of length measurements that are likely accurate from 29% to 58%. So that is, and that is why I hadn't, just starting to think about how I'm going to incorporate length measurements as I move towards diagnosing malnutrition, but that was my first step. And And again, length measurement indicators are not going to be appropriate for the first couple of weeks of life due to the diureses. And on our policy, we say that length measurements are not needed for the first 2 weeks of life because there aren't going to be useful information, and that they may be deferred in critically ill or unstable infants. Length indicators require of linear growth velocity, again, requires a second positive indicator, and similar caveats with the length z-scores. And if you notice, we used the same z-scores as we used for weight, and for linear growth velocity, we used the same cutoffs as we did for weight. Nutrient intakes, and we did use that 3 to 5 consecutive days of protein energy intake, less than 75% for mild, 50% for moderate, severe for 25% for severe malnutrition. And there are recommended intakes that have been published, and we do refer to them in the article. And this will be your preferred indicator for the first 2 weeks of life, because when you think about it, this is typically a period where the healthcare providers are prescribing intake, so it's easy to calculate exactly what they're getting. And again, with the postnatal diureses, weight and length are not appropriate. And it's important to also take in consideration that your intake goals are going to change with age, medical factors, growth histories, whether you're trying to get some catch-up growth or not. Head circumference. Altered head circumference is more commonly associated with medical morbidities and nutrient intake during the first few months of life, although a decrease in head circumference in conjunction with a decrease in weight and linear growth may support the diagnosis of moderate to severe malnutrition. And we did not recommend head circumference as a primary indicator, is because it's faltering head circumference independent of weight and height is not indicative of malnutrition. In other words, it's the last thing that's going to start to falter when you have malnutrition, and of course you want to catch that sooner. And head growth post-discharge may be a better predictor of cognitive outcomes. Mid-upper arm circumference, we know that may be a better indicator when a baby has edema because it's less influenced by fluid balance. We do know that decreases in mid-arm circumference are associated with decreases in fat or muscle stores. And we do know that mid-upper arm circumference increases linearly along with height and weight. Although the main stickling issue with mid-upper arm circumference that we came across is that there are no good references to use to make mid-upper arm circumference a viable tool for screening for malnutrition. There are other techniques to evaluate body composition and BMI, and you're probably aware that BMI curves for preterm infants are available. But there isn't evidence that BMI identifies disproportionate growth in neonates. And Dr. Olson developed those curves to be used with other growth measurements rather than a replacement of weight or length for age curves. And there are other methods I've listed here that are used for identifying body composition are suited definitely for the research setting. The nutrition focused exam, we did look at this. think about it, you definitely want to look at fluid balance when you're trying to diagnose malnutrition, and it's excuse me. So you want to observe the infants for signs of malnutrition, wasting, abdominal protuberance, and skin integrity, and that can be part of an evaluation for malnutrition. And in a critically ill infant, it may be best to use the other healthcare providers' exams to get the information you need. And so this describes what to do when preterm infants reaches term gestational age. We convert them to the WHO growth charts. When they reach greater than 44 weeks, and term neonates at an age of 30 days should be converted to the pediatric malnutrition screening tool. And you can use PD tools to adjust for gestational age in infants born less than 37 weeks when you do that. So moving forward, we feel that future research should be initiated to provide validation of the tool, to look at staffing needs. I know if I've tried to alter my documentation in the medical records to provide the information to make the diagnosis of malnutrition, it's taking more of my time, and demonstrate whether there is differences in outcomes between infants without malnutrition versus those with moderate or severe malnutrition. And we anticipate, as Pat referred to, that there will be modifications to this tool as more research becomes available, such as maybe reference standards for mid-upper arm circumference. And I apologize for that slide going off. The battery was low.
Looks like it's still connecting.
Oh, I did.
It just cut off.
Yeah.
It shows that it's plugged in. So let me see if I can. Good job.
Thank you.
It's not plugged in.
Oh.
It is now.
Okay, so I just need to press the F1 key.
This must be the strange one. Today. Okay. I can get that. Well, there it is.
And can I just use that as a mouse?
Yes, you can. I mean, is this?
Okay, thank you for allowing me to be part of this, and my charge is to take the indicators that Dina just presented to you and show them in kind of clinical practice. So I'm going to give a couple of case studies, kind of talk through the things we think about. But before I start, oh shoot. Okay. Hopefully it won't auto-advance. So my challenge is to present to you some case studies to kind of put these indicators into practice. And I have no commercial disclosures to report. So our learning objectives for today are to identify malnutrition in case study simulations of preterm and neonatal infants, talk about 3 factors that may have a non-nutritional impact on the recommended indicators, and talk a little bit more about that grams per day versus grams per kilogram per day method of calculating growth velocity. So just a quick review. Dina's talked about these already. We've got 3 indicators that are considered primary indicators, really only need 1 indicator for definition, and that would be a decline in weight for age z-score, lower than goal weight gain velocity, and nutrient intakes that are below our goal for a period of time, ranging in an extending number of days over time, with increasing severity. We've also got indicators that we think require 2 indicators, days to regain birth weight, and the indicators that we have that refer to linear growth and linear growth velocity. So we'll start with a case study. Baby girl A is a 27 1/7 week gestation infant. She's now 38 days old. A little bit of her medical history. She was intubated for the first 3 weeks of life. We extubated her to ram cannula on day of life 20. On day of life 34, she had a sepsis workup, which resulted in reducing her caloric intake. Got her on a few medications, nothing that should have too much of an impact on fluid status, theophylline, probiotics, and some sodium chloride supplementation. Here's a picture of her growth chart. When I first looked at it, I thought, well, it's not too bad. She had that initial dip. You can see, let's see if I can do this. I guess the mouse doesn't show, but you can see that she fell off her birth z-score with that initial postnatal diuresis. A little bit after the first week or so, she started to regain birth weight and was tracking for the first week after that. And then gradually over the next few weeks, she's been kind of falling off her curve. So the data that we need to obtain from the growth history as we move through this. Looking at days to regain birth weight, we said that needed a second indicator. And we want to look at change in weight for age z-scores using a consistent growth chart, as Dina said. So if you start with Fenton, you stay with Fenton. If you start with Olson, you stay with Olson. Duration of change may vary. It may be over a week, over a month, or since birth. I tend to look at change in z-score since birth, understanding that the z-score will drop off some in that first few weeks, and it may never get back up to what the birth z-score was. And then when we do the weight gain velocity that we calculate using the PD tools application, we establish a weight gain velocity, and then we compare the growth of the baby over the next period of time to that number. We like to use a grams per day goal instead of a grams per kilo per day goal, and we really want to strive for a weight gain velocity that's going to help the baby maintain their current z-score or show a little bit of catch-up. So in a situation where, for example, with this baby, they're falling off a little bit from the curve, we may pick a weight for age, a goal velocity that's a little higher than the number that PD Tools gives us. I want to talk a little bit about the different methods of calculating growth. Fenton and a large group of people did a systematic review. And those of you who know Dr. Fenton, she's very, very thorough. And she pulled every article she could find related to growth in preterm babies to see how they evaluated growth. She had a number of neos in the group who spoke different languages. I know we had someone who spoke German. There was someone who spoke French, someone who spoke Spanish, I think. So she pulled those papers too. So we ended up with about 1543 papers that we looked at. I was involved in this process. And what she found when she presented the data was that 40% of the papers reported the growth of the babies as grams per kilo per day. 32% recorded it as grams per day, and about a third reported it as change in Z-score. The change in Z-score papers were more recent papers. That's a trend that we're seeing happening in the literature. In studies, the challenge that happens is if you want to compare a nutrition and growth study, you kind of need to be comparing the same growth that's happening. So she looked at how they calculated grams per kilo per day, and she found that in 64% of the studies, it was not identified what number was used as the per kilo that you were dividing by. Some studies looked at the average of the weight between the start of the study and the end of the study, and the study might have been 14 days, it might have been 56 days, it depended. There are a couple of papers that talk about using an exponential calculation to calculate what kilo you should use. Some studies use birth weight. Some studies use the lowest weight the baby ever had. So when they got down to their end of their diuresis point. So you can see, depending on what number we used as our kilo, we get a very different grams per kilo per day number at the end. So let's go back to baby girl A. So at day of life 0, she had a weight and length that were fairly well grown, 84th percentile, 74th percentile. Her Z-scores were plus 0.98 and plus 0.66. So I'm going to skip forward to day of life 31, which is going to be a week prior to the time that we're really doing our evaluation. But I want us to look at that period of time also. At that point in time, her Z-score had already dropped about 0.6 standard deviations when we're looking at weight. And here we are in day of life 38. This is the day we're actually going to assess for malnutrition. And we can see that her Z-score has declined even further. Her actual change in weight for Z-score, weight for age Z-score from birth to present is minus 1.41. This is a chart that I tend to put in my notes. We use EPIC at our institution, and it's a chart that we can build on from week to week. So we can look at how the baby's weight and weight for age Z-score has changed over time, and it helps us identify if we're noting some trends or if we need to start maybe being a little more aggressive with our nutrition therapy. So in this situation, you can see that in this last week, prior to us sitting down and doing our nutrition assessment and our assessment for malnutrition, we have a baby whose Z-score is now minus 1.41 compared to birth. It's gradually declined over the last few weeks. And we have a weight gain velocity that's about 77% of what our goal weight gain. Well, that doesn't mean a lot unless we also look at nutrition history, because we kind of want to sort out why if we want to move forward and resolve issues. So we need to look at energy and protein intake compared to goal. And we know that the goals may vary depending on whether the patient's getting fully parenteral nutrition, fully enteral nutrition, or a combination of the two. And it may change over time as the baby gets extubated, has higher work of breathing, gets weaned out of the isolette, has higher energy needs to maintain thermal regulation. So it may not be a static number that carries throughout their stay. The malnutrition indicators do focus on energy and protein intake, but we do recognize that there are other nutrients that may have impact on growth and on the development of the fetus. So we need to also just keep those in the back of our mind. So when I look at the nutrition history, we started TPN right away on first day. Got fortifiers started on day of life 8. TPN was stopped on day 26. We didn't actually get to goal enteral feeds until day 30, so we had a 4-day interval in there where nutrient intake was not optimal. On day of life 30, when we got to goal enteral feeds, we checked a urine sodium and found that it was 26 milliquis per liter. Our goal for this baby was a urine sodium around 40 or greater, so we started an oral sodium supplement. A few days later, this is where the sepsis workup came in. We cut the feeds by half. We started IV fluids, and a few days later, we got the feeds back up, went to 27 cal to keep fluids a little more restricted, and about 4 days after we cut our feeds in half, we got back up to goal enteral intake. So you can see from this, we've had a couple of things that have happened between day of life 30 and day of life 38 that may have impacted growth. Took us a little while to get to full enteral feeds after we stopped the TPN. We had some total body sodium deficit that may have had an impact on growth. And we had another period with that sepsis workup that gave us another 4 days of not optimal intakes. So when we look at the nutrient intakes of this baby over the past 5 days, you can see that when we stopped the TPN, or when we cut the feeds in half, our calories dropped down pretty significantly, and then gradually got back up to goal. So is this patient malnourished using our criteria or not? No. Just raise hands. No. What about mild? What about moderate? Okay. What about severe? Okay. So if we look at the change in weight for age Z-score of minus 1.4, that's actually comparable with a moderate diagnosis of malnutrition using our indicators. The energy intake out of the 5 days of the previous week, about 75, or about 3 of those days were less than 75% of goal. So that actually also fits in with the moderate category. So this baby's probably somewhere in that mild to moderate range. Following our indicators, I would probably assign them as moderate. But you can notice, if you look at this infant's trend over time, we've really seen kind of a gradual decline in their scoring for malnutrition. So whereas at 29 weeks, the baby really wasn't considered malnourished using our criteria, at least our weight and our goal growth velocity criteria, in the subsequent days, we've seen a kind of gradual decline in what we would assume is nutrition status. Okay, here's our second case study. This is a little bit bigger baby, 35 and 6/7 weeks. Now day of life 21. Admitted to the NICU for management of gastroschisis. The surgeons put the bowel in a silo on day of life 0. Were able to close the abdominal wall on day of life 8 and started some trophic feeds on day 15. Baby was on parenteral nutrition support throughout the course of this. And here's a picture of the infant's growth chart. So at birth, the challenge here is that we have 2 weights that happened within 16 hours of each other. We had the weight when the baby had all the wet gauze drapings on, or all the wet drapings on over that defect, and we had the weight that occurred prior to closure of or placing the bowel in the silo. And you can see there's quite a difference, discrepancy in weight for HZ score. The one from birth is just minus 1.39 0.39 standard deviation. So shows some SGA, but the one at 16 hours of age is actually quite a bit different at minus 2.19 standard deviations. What we noticed over the subsequent couple of weeks is that that Z-score fell off a little bit and then was gradually starting to improve. So if I compare the weight for age Z-score at current to what the birth measurement was, it's minus 1.26 standard deviations. If I look at it compared to that day of life 1, right before we put the silo on measurement, it's a minus 0.52 standard deviations, so not nearly the degree of discrepancy. The baby regained birth weight on day of life 20, regained their day of life 1 weight on day of life 10. Showed a weight gain velocity over the past week that was 113% of the estimated goal based on his age and size. Goal parenteral intakes of our kind of target of greater than 90 calories per kilo, greater than 3.5 grams of protein per kilo, were achieved by day of life 4. And infant, even though we started trophic feeds on day of life 15, we maintained parenteral energy and protein intakes at that goal rate without weaning because we were being very cautious with our enteral advancement. So the infant was consistently receiving parenteral nutrient intakes of 90 to 95 calories per kilo and 3.5 grams protein per kilo. So is this infant malnourished using our indicators? No? What about mild? What about moderate? What about severe? So this is kind of a hard call. He's kind of borderline. If I use that 16-hour weight for age Z-score or weight and compare our current weight, look at the level of nutrient intakes that we've had, I would probably call him no in terms of malnutrition. But we know that his risk for malnutrition is high. He's got the history of SGA. We know he has altered GI motility from the gastroschisis. He has ongoing dependence for parenteral nutrition support. So in summary, the preterm neonatal indicators for malnutrition provide a method to assess for malnutrition and to evaluate changes in nutritional status for infants born less than 37 weeks and term infants less than a month of age. Early identification of malnutrition in preterm infants neonates may assist us in adjusting our medical plan of care and improve our nutritional status and nutritional outcomes. I've talked some with the coders at our institution about the impact that the malnutrition diagnosis would have on the neonatal population in terms of reimbursement and length of stay. She's pretty doubtful that it's going to have much of an impact because these infants have such high risk morbidities starting out. So the addition of a malnutrition diagnosis on top of that's probably not going to add a lot of extra. But I think the important thing of having a specified tool to kind of monitor nutrition status over time is really to help us have a good handle on how the baby's progressing. Are our goals appropriate? Do we need to be changing our direction of therapy to help our infant have the best possible nutrition status over the course of their hospitalization? Obviously, we need to work to validate these tools, make sure that this data that we're using is giving us accurate and appropriate information in relationship to long-term outcomes. But I think it's a great start for us to move forward to assess the adequacy of the preterm infant's nutritional status. And I've included a few references which will be on the slides that you can look at through the Aspen website. relating mostly to the studies that I reviewed. Thank you for your time and attention.
Sorry.
So I don't see that we have mics in the, but I have a handheld mic, which I will bring around if anybody has any questions. I do have one comment, though. I know that some people are in NICUs that are not of quite as high acuity, and if you do diagnose malnutrition in those kinds of, it can affect your case mix index in those hospitals. So diagnosing malnutrition can affect that in some lower acuity hospital settings. So it can make an impact in reimbursement and ICD-10 codes in some institutions.
Yeah, because I think that's going to differ quite a bit, because when I talk to the coders in my institution, they seem to feel that we could increase severity of illness and reimbursement with this. But my main thing was to, as Susan alluded to, was to spotlight nutrition and make sure it's at the forefront on a daily basis.
Okay, so if you have a question, just raise your hand and I will come over with my handheld mic.
My question is, what standards are you using for the weight gain goals, and are they the same for the IUGR babies?
I'm sorry, can you repeat that?
Weight gain goals, what are you using for standards, and are they the same for the IUGR babies?
So the weight gain goals that we're really using are derived based on that PD Tools website. So if you type in weight and gestational age and gender, it gives you a weekly weight gain that will maintain them at their current percentile. And that number changes as the child changes in size and changes in gestational age. And so that gives you a ballpark number. I divide that by 7 to give me a weekly goal. And then obviously in a baby that you feel is not moving in the right path and you want to see better weight gains, we would increase that goal. I don't think, as Dr. Goldberg alluded to, I don't think that there's good standards for what % you need to increase goal weight gain for catch-up, because nobody's really come up with a good definition of catch-up. I think catch-up varies a lot depending on whether it's an acute process or a long-term process, whether we expect the symmetric SGA baby to ever get all the way back up. There are other factors that play into that, or whether it's an acute malnutrition episode that we really would like to get them back up to a higher Z-score, more comparable maybe to what their birth measurement was. At times, just to give me a random number, this is not scientific in any way, if I have a baby who is, let's say, at the 10th percentile, and he's falling off the curve, and I want to see catch-up growth, I might, in that PD Tools website, it'll tell you what the weight at the 50th percentile should be, and I'll just type that in instead. It picks up the grams per day goal by a couple. I mean, it's not a huge increase, and I might use that as my target goal instead of as the goal based on what their current weight is. Does that make sense?
Yeah, because I concur with Susan, and I think you need to keep in mind what's the reason behind them being SGA, or are they really IUGR, and then think about what is a realistic goal for that baby. So it isn't cut and dry or white, gray, black and white. It will require some clinical judgment. I mean, I see an LGA baby born of a diabetic mother, and the Z-score is going this way. That's probably expected and may not necessarily be malnutrition, but then again, you have to look at the other things going on in terms with that baby in terms of the medical condition and intake.
Hi.
Yes.
I just had a question about if you could comment on how you see these indicators overlapping with the pediatric. And so, for instance, a 6-month-old who was premature and is now, okay.
Okay, so your question is, how do you go from the neonatal to the pediatric?
I think once,
Go ahead.
and Dina had a slide that spoke to this, I think you have a preterm baby who's now reached term, and he's now term-adjusted age. And the pediatric indicators actually start at a month of age. So what we've said is once that preterm baby reaches 44 weeks post-conceptual age, so a month post-term, at that point in time we move to the pediatric indicators.
Exactly.
Yeah, and what I personally do is to also look at that baby, because I discussed with Dr. Fenton when you make the transition, and my conclusion is if I have a baby and I know that this baby is like 43 weeks, and I know the baby isn't here much longer, I'm not going to make the transition just to keep my data, the change in the data. But if this baby is one of my short gut kids who probably will probably be shipping off to nursery school from the NICU, I'm going to make that transition.
And I
They
think
both use weight gain velocity.
Thank you, all three. Just a quick question on length deviations and how you think that may manifest in future diagnosis for neonatal malnutrition, looking at Sarah Remmel's data, and then just what are your thoughts on that, incorporating that?
I missed the beginning of the question.
What are your thoughts on possible manifestations of growth deviations from the length perspective over time? This was, heavily weight-based, and so I'm wondering your thoughts on that, since long-term, growth is usually seen by stunting.
We had a long discussion about length, and that probably took multiple episodes of our meetings. But the challenge that we face with length is that the measurements are really inaccurate. Now, if you have an institution that has well-trained people using correct techniques to do length measurements, I think that length is a valid thing that we should be focusing on. And I think, truthfully, that's what we're all striving for. I mean, we want the babies to gain in weight, but we really want them to gain in length. And I think we need to work towards
length gain velocity as an indicator, but we didn't use it in the paper because it was not because of the accuracy of the data.
Do you feel if they're moving forward, if we had any data, though, that would support, multiple increased comorbidities over time with length deviations, that would help prove the point that maybe even short-term losses with good measurements could push that up to a higher diagnosis criteria?
Yeah, I guess one of my thoughts was when we think about malnutrition, the first thing that falls off is weight. That I was a little concerned that if we wait to length falling off as being the marker, that we might miss some of that early malnutrition that happens before we get to the length falling off. But I think if we have good, accurate length measurements, and we have data that shows morbidities with that, then I think absolutely that's something that would be a very valid change in this proposed screening tool.
Yeah, and personally, I would, at this point, given that, as I mentioned, I have issues with accuracy of length measurements in my institution, although they're getting better, that would be something that I would look at if I feel like I need to plead a case for a nutrition intervention in a baby, because that would support maybe that this baby needs extra protein if I don't think, this baby has been taken off of human milk fortifier early and growth seems to be faltering. So I think there are ways to use it in conjunction with your weights.
Thank you, all three of you, for your much-needed work in this area. We've been using the pediatric criteria, but we have really found a gap, so I really appreciate your work on this. My question is related to the nutrition-focused physical exam in this population. So much of the nutrition-focused physical exam in pediatrics is extrapolated from the adult. Is there any role for this work group to talk about nutrition-focused physical exam in the neonatal preterm population? Because that is an area that we have seen. And also, second part of that question, do you recommend doing a nutrition-focused physical exam on these patients? And if so, how would we go about getting our institution staff trained that work in the NICU to do that type of level of exam?
EGAD.
You want me to, I'll start. I think personally with the nutrition focus exam, and I think there would be a role for that, but there are several things to think about it as to implement something like that in the NICU. And at this point, I'm one for using what has already been documented by healthcare professionals that are doing an exam, because I personally do not want to be another set of dirty hands waking up a baby that doesn't really need to be stimulated to do that. And then the logistics of doing it on the number of babies when I'm the only person is hard. And I think those are issues that need to be worked out.
Exactly. That would, and what I was just talking with Pat too, about what the criteria would be.
Yeah, and that's why we definitely left it open and are looking forward to probably in the future when these are re-looked at that may be a viable indicator.
And then do you have a recommendation as to what age you would start doing more of a nutrition-focused physical exam? Because that's been another thing within our infant population. At what age do we start documenting that? We have all of the, out of the nice A&D booklets that have been created, we have that nice table, in our EPIC documentation, which is great, but at what age is that validated criteria? We've struggled with that concept.
Yeah, and that's not even infant-based, so.
I can't speak to that. I don't think we have enough good data that really speaks to this population to
We don't even have it for under 5, so. Yeah, that's years down the road, yeah.
Yeah, because I agree with what Dr. Valentine has said, because at least in my unit, and it's just how I feel I can best use my time. I'm not one that's going to go up and examine the baby, but I think my time is, I can talk to the nurses, I can talk to the attending and find out information about muscle tone, and at this point, that would be useful information in helping you determine in some of these cases, as Susan illustrated, that you know, is this mild, is it moderate, or is it even mild malnutrition?
I do think there's a lot of benefit to going at bedside, not putting hands on baby, but just looking at them and their tone, and are they moving, and do they look like, as one of our terms is, puffy or not? You know, I mean, just some kind of, and then watching that over time. I think sometimes you can have these growth chart numbers that tell you one thing, but when you actually look at the baby at bedside, you get a different sense of how they're doing. But that only really works is if you're looking at the baby serially over time. I don't think we're ready to do hands-on, opening the mouth and, you know, those kinds of things that I think they talk about with the adult physical exam. But I do think that some of that visual inspection is very helpful.
Hi.
Yes, Jackie.
Thank you so much again for this work. It's great and exciting moving forward. I wanted to piggyback on the discussions about linear growth. Assuming that we do have accurate measures, I noticed that the mild, moderate, and severe definitions are the similar z-score changes to weight. I'm familiar with the Rochow data, but I'm just curious, I believe that was mostly weight-based.
Yes.
How did you define those z-scores? Is there a reference for that, or where did you pick those various?
The reference for the length z-scores? There's not. So we just took the same assumption that we took through the Rochow data with his, as you said, is weight, not length, and transcribed that over to the length.
Yeah, and this was with input from Dr. Fenton herself that we came up with those actual z-scores, and again, made that decision that there wasn't information to do anything different than for ease of use of the indicators, to keep the z-score cutoffs the same.
On the question of like doing like the mid-upper arm circumference, I've used it in unusual cases like conjoined twins when I'm trying to, you know, keep the babies, you know, find out what they're doing over time, just using themselves as control. And it's really tough to do, even using the, you know, the WHO little, you know, tape measure, because babies are, they're a little bit flexible. And I had a hard time, it was me doing it each time, but how, when you draw it up, you know, I found it was hard to decide exactly what was the point to use, because they're just a little tougher. And then, you know, kids that I've done that are older, they're a lot easier because their arms are more defined, I guess I would say. So I would say some of the physical exam, even though like in the, you know, I think in the future we may move to this, especially in coordination with another healthcare provider, standing there maybe asking them to do some things for us. But some of the stuff for the babies, it's not clear cut.
We actually found, we did mid-upper arm circumference on conjoined twins too, and we found it took the bedside nurse to get the baby positioned correctly and 2 dietitians so that we could each do the measurement and compare. So.
Hi, I just have a question from the research standpoint. Historically, you know, all the growth charts that Fenton based her revised growth chart on are based on completed weeks of gestation for the measurements, and also and historically, you know, a lot of research papers have based their data on completed weeks. Do you still recommend using completed weeks for reporting growth in research studies? Because I know, obviously, you know, in the NICU, people are following, you know, weeks plus days, you know, and computing that way. And I'm just not sure how that settles out, you know, whether we're overestimating what we need to get, because, you know, when they used completed weeks, of course, they were taking all babies like between 23 and 24 weeks and averaging that, and that was the weight, mean weight for 23 weeks. So do you have a opinion on that?
My understanding in the Fenton 2013 growth chart, she has 2. And the most recent one, which was 2013, she actually adjusted for that. So it's her 2013 growth chart is not based on completed weeks. it's based on weeks plus days.
And she also smooths that disjunction between the WHO and the preterm.
Is that right? I thought that the data that she was using was from the previous studies that were all based on completed weeks, like the Canadian study, her previous study, the Olson study, that were all based on completed weeks. But am I wrong on that?
No, I need to go back and look into that in more detail. From reading her 2013 paper, it sounded like she had factored for that in some manner, and I'm not sure how she did that.
What was the
But
question?
she said that you should plot using weeks plus days instead of and completed weeks. Her 2009, I think, was her first growth chart. You did plot just at completed weeks, not weeks plus days. And I'm not sure if she used a mathematical calculation to smooth that or how that occurred. I'd have to review the paper.
I want to thank everybody for attending today, and especially our speakers. So thank you, Dina and Susan, for a wonderful presentation. Thank you, ladies and gentlemen.